Hello class, I'm Belinda Rincones and the topic I'll be presenting on today is breast cancer.
Good evening, Ms. Lopez. What brings you to the clinic today?
Well, I was doing my monthly self-examination of my breast and I found a lump in my left breast.
Okay. And you hadn't felt that lump there before?
No.
Okay. Let me take a look. Is it about right here?
Mm-hmm.
Yes, I can definitely feel a lump there. What I'm going to have to do is we're going to order some lab studies and some diagnostic studies to see what's going on. As soon as I get those results back, I will call you and we will go over those results, okay?
Okay.
Breast cancer remains the most common form of cancer in women between the ages of 25 and 75 years of age and continues to be the most frequently diagnosed cancer in women in the United States. Although there has been a decrease in mortality, breast cancer remains the second leading cause of cancer deaths in women, and nearly 40,000 women die of breast cancer each year in the United States. African American women are 40% more likely to die of breast cancer than Caucasian women. Studies have shown African American women delay getting follow-up care after an abnormal mammogram. They also have fewer women who receive surgery, radiation, and hormone treatments. Nationally, the absolute risk for women being diagnosed with breast cancer at some point in their lives is 1 in 8. Breast cancer in males does occur, but is 100 times less common than the occurrence found in women. For the purpose of this presentation, I will be covering breast cancer in women.
Good afternoon, Ms. Lopez. I'm afraid I have some bad news. I got the results from the test that we ran the other day, and you do have stage 2 breast cancer. This is an early stage and it's very effectively treated, okay? I know this is not what you wanted to hear, but I'm going to go over with you what's going on in your body, go over some treatment options that are available to you, and some interventions that we can go over that will help you, and then we'll start a plan of care for you. How does that sound?
Okay.
Okay.
The cell cycle is important to understand because this is where the development of not only breast cancer, but cancer in general occur. You can see where the cell cycle begins. Phase 1 is a period of growth and activity. Restriction point is where cells decide whether to continue on in the cycle. S phase is the synthesis phase and is where DNA replication occurs. In the G2 phase, cells continue to grow and prepare to divide. The last phase is the M phase. This is where mitosis takes place and you have cell division forming 2 new cells. The main purpose of the cell cycle is to ensure that the DNA is replicating once during the S phase and that identical chromosomal copies are distributed equally to 2 daughter cells in the M phase. This is where it gets complex. The cell has many cell signaling systems that promote proliferation. Even though adults are no longer growing, many cells in an adult's body continue to divide to replace worn-out cells. These signals tell a cell when to enter the cell, how long to stay there, when to divide, and it even tells the cell when to exit the cycle. If any of these signals controlling the cell cycle fail, cell division can go unchecked. G1 is the phase where oncogenic processes target. During this G1 phase, cells respond to extracellular signals by either advancing toward another division or withdraw from the cycle into a resting or dormant state. Cancer cells abandon these control signals and continue on in the cycle. One of the reasons these genes proliferate uncontrollably is a series of permanent mutation takes place in the tumor suppressor genes and proto-oncogenes. With all this taking place, the mutated genes interfere with the signal or can cause an incorrect signal to be sent to the cell. Most mutations are repaired by the cell, but in rare cases, mutations do not get repaired. And if this happens and it's not repaired before a cell copies its DNA and divides into 2 cells, that mutation is passed on to the 2 new daughter cells and becomes permanent. are the theoretical steps in the development of cancer. In the initiation phase, genetic mutations are inappropriately activated. It has been suggested that several mutations may be necessary to achieve full malignancy. Promotion stage is where the mutant cell differentiates. Proliferation is regulated by numerous hormonal growth factors. This is why hormones may act as promoters of certain types of cancer. An example of this is the relationship between estrogen and breast cancer. Uncontrolled cell proliferation is the hallmark of cancer. The progression stage is where the mutant proliferating cells begin to exhibit malignant behavior. Cancer cells have numerous abnormalities of chromosome structure. Because the conversion of a normal cell to a malignant cell requires multiple steps, as you previously saw in the cell cycle, there are many opportunities to intervene this process. And I quickly wanted to mention a tumor suppressor gene that is inherited called the BRCA1 and the BRCA2. These genes have been mutated somewhere along the germline, and if you've inherited these genes, you have a 30 to 50% lifetime risk of developing breast cancer. An exam of the body is needed to check for general signs of health. If you're looking for any signs of disease, feeling for any lumps, or seeing or feeling anything that's unusual. Also, getting a good patient history with past illnesses and treatments that might suggest breast cancer is good to also do. The clinical breast exam. A healthcare provider will need to carefully feel the breast and under the arms, checking the lymph nodes. Cancer of the breast can manifest clinically as a mass, a puckering, nipple retraction, or unusual discharge. Cancers many times are found by women themselves when they notice a change in their breast. Breast cancer often manifests as a solitary, painless, firm, fixed lesion with poorly defined borders. It can be found anywhere in the breast, but is most common in the upper outer quadrant. Mammogram is an X-ray of the breast. This is the only effective screening technique for early detection of clinically inapparent breast lesions. Mammograms can disclose lesions as small as 1 millimeter in size and the clustering of calcifications. Mammography has a sensitivity of 80 to 90% for the detection of breast cancer. So this is important to remember. Even if there is a negative mammogram, but the patient can feel a palpable mass, it definitely needs further evaluation and potentially a biopsy. Ultrasound is useful to differentiate cystic from solid tissue in women that have nonspecific thickening. The echoes form a picture of body tissues called a sonogram. These will help see any masses that are present. And what you're looking for in the sonogram is a lesion that is ragged in appearance. The MRI. This is also available as an additional diagnostic modality for breast cancer. It's recommended to supplement conventional mammography in women with radiographically dense breasts or patients who have a strong family history of cancer or who are known to be carriers of the BRCA1 or BRCA2. The MRI makes a detailed picture of areas inside the body and help locate any lesions. Biopsy is done to check for signs of cancer. There are 4 types of biopsy, with each biopsy looking for malignant cells. Excisional biopsy is the removal of the entire lump of tissue. This biopsy is the only definitive diagnosis of breast cancer. You have the incisional biopsy. This is the removal of part of a lump or sample of tissue, and again looking for any malignant cells. Core biopsy is the removal of tissue using a wide needle. And then the fine needle aspiration biopsy is the removal of tissue or fluid using a thin needle. This method can identify the presence of malignant cells, but it cannot differentiate in situ from infiltrating cancers. Some of the treatments for breast cancer. Surgery. There are 2 types of surgery. Those are a lumpectomy, which is the removal of the tumor, and they also remove a small cancer-free margin of the normal tissue. The mastectomy is the surgical removal of the entire breast, and just know that there are several different types of mastectomies. The radiation therapy is just a high-energy X-ray that kills cancer cells or any remaining cancer cells that still remain near the tumor site or elsewhere in the breast after the tumor has been removed. Chemotherapy are drugs used to destroy cancer cells, and they work by stopping the cancer cell's ability to grow and divide. Chemo can be given intravenously or taken orally. A patient may receive one or a combination of different drugs. The hormonal therapy, which is also called endocrine therapy, is an effective treatment for most tumors that test positive for either estrogen or progesterone receptors. This type of tumor uses hormones to fuel its growth, and this type of therapy will block those hormones. And then the last one is the targeted therapy. This type of treatment targets the cancer's specific genes, proteins, or the tissue environment that contributes to cancer growth and survival. Two health promotion interventions I wanted to hit on are alcohol and obesity. According to a controlled case study, high levels of alcohol consumption were associated with increased risk of breast cancer. Heavy alcohol consumption, which is defined as 3 or more drinks per day, is associated with an increased risk by 40 to 50%. According to the study, healthy women should not exceed 1 drink per day. The other intervention I looked at was obesity. And obesity is found to be one of the many established risk factors for the development and prognosis of breast cancer. Obesity around the time of diagnosis is associated with poorer survival and increased likelihood of recurrence in women with breast cancer.
Thank you for giving me all that information. That really helped put me at ease.
Okay, well, I'm glad. And I know that that was a lot of information to take in at one time, but if you have any questions or any concerns, please feel free to call me, okay?
Okay, thank you so much.
You're very welcome.
And here are my differential diagnoses. The first one that I picked was fibrocystic breast disease. And fibrocystic disease is the most frequent lesion of the breast and most commonly seen in women 30 to 50 years of age. These lesions, when felt, can easily be mistaken for a malignant mass. Fibrocystic changes usually present as nodules, granular breast masses that are painful during the menstrual cycle, unlike cancer tumors that are usually painless. Diagnosis of fibrocystic changes is made by physical examination. Mammography will sometimes be used, and an ultrasound can also be used to differentiate a cystic from a solid mass. But any suspected lesions that are indistinguishable should undergo biopsy. And usually after the diagnosis has been made of fibrocystic breast disease, the treatment is usually symptomatic. My second diagnosis is atypical ductal hyperplasia. These lesions are commonly detected as mammographic densities or calcifications. Because it is detected on the mammogram, you don't know whether it is a finding to be concerned about. The hyperplasia is accompanied by replacement of the normal epithelial cells lining the ducts or the lobules with atypical cells resembling those of carcinoma in situ, such as monomorphism, regular cell placement, and round regular spaces. The difference lies in the extent of involvement of the ducts. In the ADH, the lesions occupy only part of the involved space, while ductal carcinoma in situ occupies the entire duct space and often adjacent duct spaces as well. The patient would have a core needle biopsy done. This benign breast disease puts the patient at greater risk for breast cancer. And then my last diagnosis was fat necrosis. Fat necrosis in the breast is the death of fat tissue after trauma or injury to the breast. Fat necrosis can mimic carcinoma of the breast. Fat necrosis has some of the same clinical signs as breast malignancy. They have a painless mass in the breast that is firm, ill-defined, and poorly mobile. Skin thickening and retraction may also be present. A mammogram cannot differentiate fat necrosis from a malignant tumor. If fat necrosis cannot be distinguished from carcinoma by clinical observation or mammography, an excisional biopsy must be performed to diagnose.